Hello, my name is Marcela Mazo Canola. I'm a breast medical oncologist with UT Health San Antonio, Mace MD Anderson Cancer Center. And I'm here this morning joined with my colleagues to have a conversation about metastatic hormone receptor positive, HER2 negative, PIK3CA mutated breast cancer. Introduce yourself.
Hi, everybody. My name is Akshjot Puri. I'm a breast medical oncologist, and I practice at Houston Methodist Neonatal Cancer Center in Houston, Texas.
Hi, good morning. My name is Giancarlo Moscol. I'm an associate professor of breast medical oncology, also at the University of Texas MD Anderson in Houston.
Okay. Well, very good. Thank you for that kind of introduction. So I wanted to get your all's opinion. So we see a lot of patients with metastatic HER2 negative, hormone receptor positive breast cancer, and we have excellent data with the CDK4/6 inhibitors in the first line setting. And we know that when patients have a good response, we can see a response up to 2 years in some of these patients and beyond that. But obviously, we struggle and we see that we lose a lot of patients when they progress and we have to make decisions about the second line setting. So let me get your opinion, Akshjot, and how do you approach those patients and what is your current practice as far as biomarker testing from the get-go? And how do you decide how you're going to sequence these patients after they progress in that first line?
Yeah. So I think as the FDA approvals and the options are increasing, it's becoming more and more complex even for breast oncologists, let alone oncologists who are actually doing every type of cancer. So I feel it's hard for us to keep up to. With the current FDA approvals, I really look at their mutation status, ESR1 mutations, PIK3CA mutations, AKT-P10 pathways, their germline mutation status. Also, very importantly, I look at how long they've been on a prior CDK4/6 inhibitor. I think that also informs how the tumor biology is and how they may respond to a future endocrine-based therapy versus moving on to a further more aggressive antibody drug conjugate. So those are the factors that I look at, and obviously patient comorbidities, if they have poorly controlled diabetes, they're obese, or performance status. I think those are definitely factors that I consider.
Yeah, I agree. And it's important to kind of learn to read the room, right? Like some patients are going to have a more aggressive pattern of recurrence. Some others are going to just have bone isolated or bone met only, less symptomatic. And depending on that and the performance status, the age of the patient, then you need to come up with the best treatment strategy, right? I always tell the patients, the goal here will be to try to help make breast cancer a chronic condition, ideally, right? So if we can help you stay on these treatments for months or even years, then and while keeping you asymptomatic, that will be the best outcome for you. Now,
Giancarlo, let me ask you this. Do you sequence all your patients from the get-go, even when you're starting your CDK4/6 inhibitor? Do you do next generation sequencing on tissue? Do you accompany that with a liquid biopsy? What's your approach to biomarker testing in these patients?
I do. Of course, I have the bias of practicing at an academic institution. So we like to always get a tissue biopsy of the most distant lesion. I would say, tissue is always the issue, as they taught us in fellowship. And I would say that in terms of magnitude, probably tissue biopsies of distant lesions, about 70% of patients end up getting some. When they have bone-only mets, that's kind of a judgment call, right? Like depending on the procedure, where the bone met is located, the comorbidities of the patient. If I'm in doubt, I just go ahead and do a liquid biopsy, specifically to see if the patient may have an actual mutation that I can tap on later. That being said, I always explain to my patients the fact that we're checking for alterations or mutations doesn't necessarily mean that we'll be able to target those, right? So it's important that we just build a case and we are able to know as many of the receptors and abnormalities present so we can plan and sequence in the future, always trying to keep a window open for, modifications in the treatment down the road.
Very good. And Akshjot, so when we identify patients with PIK3CA mutations, that is roughly about 40% of the patients that we see in the metastatic setting. What factors do you take into account to decide, okay, this patient is a good candidate for a PIK3CA blocker such as Capivasertib or alpelisib? And how do you choose in between the two? I mean, are you using more Capivasertib? Do you still resort to the use of alpelisib? And what are your deciding factors to make that decision for that patient?
Yeah, so I think it's a good option to have 2 FDA approvals in that sector. Obviously, we all understand that alpelisib has been around for a long time, and people may have a little bit more experience with it just because they've used it for a long time. But in terms of side effects, I do think that Capivasertib does have the hyperglycemia side effect, but I don't see it as often. I see it in alpelisib. So especially if I have a patient with like an A1C on a higher end, and where I feel that they may be at a higher risk for hyperglycemia, I may prefer Capivasertib even at a lower dose for them. And alpelisib, I do think like, with rash and diarrhea and other side effects as well, sometimes can be a harder to tolerate drug for a lot of people. Being oral does not mean that it's something that's easily tolerated, which I think patients get very excited about, but it is important to have those discussions regarding side effects. I'm not saying that Capivasertib does not have side effects, but also the 4-day, 3-day off dosing does make it a little bit more easier for getting a treatment break. And now there's a blister pack, so they're not mistakes, because I think initially when it came, people took it like nonstop. But yes, I think it's just nice to have those options, and dose reduction is a good strategy.
Good. Giancarlo, when you have these patients, they're PIK3CA mutated, and we were having a discussion about biomarker testing. How do you approach those patients that perhaps have a co-mutation? You see an ESR1, you see perhaps a PTEN in the same patient, perhaps the response that they had to their CDK4/6 inhibitor, you were not very excited, or they have a lot of visceral disease. So what's your approach, or what factors do you take into account to say, okay, I'm going to go with perhaps, a doublet with Capivasertib fulvestrant, or no, I'm going to try elacestrant first? What are your thoughts?
Yeah, so it's the good news is that it's not a frequent scenario, but technically up to 10% of patients may be co-mutated, and that's where I also try to read the room. So what is the pattern of progression? If the patient is progressing with symptomatic visceral metastases, had a shorter time on treatment in first-line therapy, for example, then I would consider the patient is now beginning to show some of the signs of becoming endocrine resistant or endocrine exposed. And on those patients, I would prefer to go after the PIK3CA pathway, right? It tends to be the most important driver. Versus, on the other hand, if you had a patient that probably stayed 2+ years on a CDK4/6 with an AI, and now is only showing minimal bone metastases, then my guess would be that ESR1 is likely driving that progression. The patient is becoming less symptomatic. And then I would probably try to go with elacestrant on that specific patient, knowing that I can always save the PIK3CA pathway for later, right? You can try to go after that one in third line instead.
Yeah, very good, very good. Now, Akshjot, now to, pick your brain a little bit. Is there any specific patient in which you will jump into, something more aggressive like an ADC in the second setting, despite the presence of a PIK3CA mutations? And if that's the case, how do you make that decision?
Yes, in fact, actually last week I had a patient like that. So she had about 5 positive lymph nodes a year or 2 years ago, had all adequate treatment, anthracycline-based chemotherapy, radiation. And this was on Verzenio, that she had a progression. Very heavy disease burden, liver mets, bone mets, and she does have a PIK3CA mutation and also has an ESR1 mutation, right? So that is where everything that Giancarlo just mentioned really comes into play. I completely agree that an ESR1 mutation should be targeted when the disease space is a little bit slower. The responses can take a little bit time. So when you have that luxury of time and the patient is asymptomatic, I think it's excellent. The drugs are very well tolerated. And the combo approach is also, very promising in terms of SERD in combination with CDK4/6. A PIK3CA mutation, on the other hand, also is the endocrine backbone, can make that response not super quick. And in a patient like this, where there's an impending visceral crisis, they're getting symptomatic by the week, tumor markers are through the roof, I generally don't feel very comfortable, just gambling with the side effects with the PIK3CA as well. So in a patient like that, I did start her on T-DXd this week, pretty much. So this is her first dose, and I'm keeping my fingers crossed that really helps with like the cytoreduction, the symptoms, and we don't know how these tumors will behave after Enhertu. We were just having an off-camera discussion that the tumor biology changes with each drug we use.
You're right.
The tumors pre-CDK4/6 era, we used to love fulvestrant. Everybody would have a great response. And now after CDK4/6, you'll see like a 2-month response on fulvestrant. So similarly, I don't know if I can give them a 7-8 month PFS on Capivasertib or alpelisib post-T-DXd, because we don't know that tumor biology, but I would certainly try to give them a PIK3 inhibitor maybe in the future if they are in a place where they can try oral therapy.
And I think the key concept there is the time to response, right? So when you see that the patient is crashing and burning in front of you, they're going into visceral crisis, lymphangitic spread, clearly highly symptomatic, or brain metastases, then on those patients, I don't play games, because your next shot is going to be your best shot.
Right.
And if they're HER2 low or ultra low, they clearly meet criteria for DESTINY-Breast06. I just go with trastuzumab deruxtecan, right? So that is second to none, significantly better than chemo. We know that. On all the others, yes, you need to kind of think of this about sequencing, preserving quality of life, and delaying the need for chemotherapy in order to improve quality of life for the patient.
So obviously those cases, thankfully, they're not very common. And when we have those patients, we already kind of know that the endocrine pathway is done, and they're behaving very differently, like, patients that have endocrine sensitivity. But this leads me to have a conversation about SERDs and SERDs combined with medications such as Capivasertib. We have early phase data in combination therapies with SERDs and PIK3CA inhibitors that seems to be promising with a very favorable side effect profile. Have any of you done this kind of combinations already, as far as combining Capivasertib perhaps with medications such as elacestrant?
I have not done that yet, but I'm really excited for it. I do think that's the future. SERDs are the future for endocrine backbone. And I also think that PIK3CA inhibitors will keep evolving over time. I think we are getting better at targeting the mutated version, not the wild type version, and decreasing the side effects. So I think the newer generations combined with the SERDs is the future. But I have not personally done it yet.
Yeah, no, only on a trial. I mean, we have data for phase 1. I think that I agree. The beating a phase 1 is mostly focused on safety and tolerability. The good news is that, yes, the combination is safe, which comes as no surprise, right? I mean, we know the SERDs are medications that are decently well tolerated. They have minimal toxicity. You're not producing any cardiac problems, minimal GI toxicity. So the advantage there will be that it gives you the opportunity to compound them with something else. I think that, for example, using Capivasertib and the fact that it can block the AKT and the PIK3CA pathway can allow to rescue back some of these patients. And it's possible. We know that when you do combination SERD with something else, like SERD abemaciclib, or you do SERD everolimus, or SERD Capivasertib, that the benefits may no longer be restricted to only ESR1 mutant patients, but rather you end up getting a more of an all-comers effect. So that advantage means that you don't need to limit the prescription to the ESR1 co-mutated, right? The ESR1 PIK3CA, but rather all PIK3CAs in order to rescue them back. But I think we're going to probably learn a little more on that over the next couple of years.
Yes, and probably after we treat those patients with SERDs in combination, I think we're going to have another problem. What do you do after a SERD? But that's probably for a different day. Now, speaking of, the two of you alluded to side effects, tolerability. I think all of us are well trained. We know hyperglycemia, rash, diarrhea. Is there anything that you proactively do ahead of time before you start these patients on PIK3CA inhibitors to mitigate or avoid the side effects? Do you do dose escalation? Do you put them in something specific if they're diabetic? Because let's face it, that target A1C, I don't think is necessarily applicable in the real world, because we have a lot of obesity and a lot of patients that have comorbidities such as diabetes. So what is your recipe as far as what's your, process when you're starting these patients on TrueCap?
Yeah. So I think I really take into context like how the patient's performance status and their general comorbidities are. If there is a patient who's like a really bad diabetic, but they do fit they're the textbook person a PIK3 inhibitor should be given to, I still want to give them that benefit. I do highly encourage them to meet an endocrinologist if they are not already with one. At least in our center, it does take a couple of weeks to get an endocrinology appointment. So what I generally do is I reach out to them. Sometimes these medications can be easily prescribed until they can see the endocrinologist. Like I can easily prescribe metformin. Even if it's an SGL2, it's easier to prescribe and then they can monitor, just so that there's enough time for them to get the medicine and at least get started on it for a couple of weeks before they see the endocrinologist. I think GLP-1s are also, getting more and more common in these populations. So there is a way to optimize them for a few weeks while their TrueCap is getting insurance approved and they're getting it and doing it like more simultaneously. For a person who does not have significant comorbidities, I generally don't pre-medicate them with metformin, and I would just start them and do very close monitoring. In my experience, you generally see it within the first couple of weeks if there is hyperglycemia. And then after a month or so, if I haven't seen it, then I'll not do as frequent monitoring. I also counsel them on if they're sick or something's going on, to hold the drug and let us know, because sometimes I think that can increase their transient risk for hyperglycemia, especially elderly people.
Yes.
Low carb diet. So I think very low key measures that are high impact are helpful. And it's important to reinforce that with patients because they don't know.
Yeah.
Very frequent follow-ups. I mean, I believe that one of the advantages we have all learned from Metallica, with alpelisib, which is a very difficult medication, right, because of the amount of grade 3 hyperglycemia, is that if you select your patient population and you put them on prophylactic metformin, they do significantly better. The problem is that metformin can produce GI upset, right, so some gas and diarrhea. So do I use metformin prophylactically? Yes, but it will be probably for patients that have an A1C of 7.5. If the A1C is greater than 8%, to be honest, I prefer to hold on the CAPI until I have some form of feedback from endocrinology to get some guidance. And below 7, I don't really need to put them on metformin. And I agree, I mean, worst case scenario, there are some, for hyperglycemia, I think it's important that you tell the patient, carb counting, be aware of, physical activity. Some of these patients are already getting GLP-1 inhibitors, even online, not even through an endocrinologist.
Right. Yes.
And when in doubt, you just hold the medication and start dose reducing as needed. But I would say overall, the hyperglycemia intensity, the grade, the magnitude is not nearly as bad as what we have seen with alpelisib. And it has to do, again, with the mechanism of the medication.
Right.
Anything specifically that you do for the rash? I feel like the rash, at least in my personal experience, has been probably the most prevalent side effect. I feel like with hyperglycemia, we have very good tools. We have glucose sensors now, which have avoid, patients picking on their fingers, which obviously they don't like. But anything that you do as far as prophylactic management of the rash that you educate your patients on?
Yeah, I generally will start them on Zyrtec or Allegra just daily before I start the TrueCap or alpelisib. I know that not everybody needs that, but I do think that that definitely helps the compliance and making sure that the rash is not too intense for the people that we're going to get it. And that helps with compliance in the future because then they're more agreeable for dose reduction if their experience wasn't too terrible.
I agree. We put them on Zyrtec prophylactically. And what I usually like to do is when I start a patient, I tell the patient, okay, send us a MyChart message. Let us know that you receive the medication, right? Because there could be also a gap in time from the moment you prescribe to the moment the medication is delivered. And from that moment, I ask my nurse practitioner to bring the patient back in a couple of weeks. Because if you're going to develop the rash, it usually takes 7 to 10 days.
Yeah.
So at the 2-week mark, you should be able to see how bad this is working. And if you're already seeing that it's grade 2 or 3, maybe that's the best time to pause the medication, put them on steroids, or talk to dermatology as needed.
Very good. Thank you for those nice points for our audience. Now, speaking still about TrueCap, we recently had an update as far as overall survival. And if you remember, for example, SOLAR, which is the trial that led to the approval of alpelisib, and CAPItello-291, and they were not very excited as far as overall survival data. Does that bug you? I mean, any comments on that?
Yeah, it did not bother me at all. I think the trial was very impressive already. It had established ground. The trial was also not powered for overall survival. It's only powered for PFS. Also now in the modern generation, this placebo patients and CAPI patients have gotten antibody drug conjugates. So it's really, really apples to oranges, what the world was before the trial was conceived and now. So I think the PFS2 benefit was pretty significant. The time to deterioration of quality of life, time to chemotherapy. And I think that's what I'm trying to buy for this perfect patient for CAPI. I'm trying to delay their time to deterioration and chemo. And that will add to their overall survival in the long term, because if I add a year to their life, that is very significant. Yeah.
I agree. And it's very difficult because whenever you run a global study, the access to newer technologies and clinical trials and medications is going to be very difficult to account for, right? So, some of these patients, after they progress, it's possible they were able to resource to another PI3 or AKT-Pathway inhibitor later. And then, antibody drug conjugates, clearly trastuzumab deruxtecan has completely changed and has spoiled us in terms of response rates and expectations for PFS. So it's going to become more and more difficult to end up getting a overall survival advantage with an early intervention like first or second line, right? And I think that we just need to understand that maybe other surrogates can be used. You have PFS too. I think that's a very good measurement, duration of response, and then quality of life, right? Which at the end of the day is what you're trying to do. You're gaining time to allow these patients to delay the need for chemotherapy.
Yeah, and I couldn't agree more. Even if we were not able to prove, you know, that specific statistical mark, I completely agree with you both that this is a great medication that thankfully we have for our patients. Now, speaking of the same pathway, you know, there's a lot of exciting coming in with gedatolisib, the PAM inhibitor. It's in the early phase settings with very exciting data, and I quite frankly think that this is a medication that is going to be available to us. I will say the only downside that I've seen or heard from my patients that are currently enrolled in Victoria is the fact that it's an IV medication, which can be a disservice for these patients that are used to getting pills or injections. What are your all's impressions so far with the early results of the Victoria 1 and Victoria 2? Do you see this moving forward? Any comments on gedatolisib?
Yeah, I definitely think it's a newer generation inhibitor. Like the mechanism's very different. They're targeting more PI3K mutated, mTOR, crosstalk with AKT. And also the IV schedule was more of like, you know, also bioavailability, but gives the patients a little break. And maybe that's why we also don't see so much hyperglycemia, in addition to the mechanism of how the drug works. I do think it's also a great option for the wild type patients.
Yes.
So we really, really need more options for these wild type patients. I feel really bad when we have those 60, 70% people who have no mutation, right? And then all they have is an IV drug, which is an antibody drug conjugate. So I think this is not much different than doing that IV. And also if you can still combine it with a backbone of endocrine therapy, I do think it has a lot of promise.
Yeah.
To me, one of the most important features is that it's giving us a new tool, right?
Yes,
so
exactly.
we otherwise don't have any other way to really go after the PI3K, mTOR, AKT pathway in the patients that are wild type, right? So I think that just because of that, and because this is not using a payload, but rather an inhibitor of the pathway, it's going to be something I want to expose my patients to even before I consider, you know, doing systemic chemotherapy or trastuzumab deruxtecan, right? Again, we're in the business of trying to help these patients live longer while sustaining their quality of life. The IV, I think I would expect to get some pushback on some patients, you know, as you're saying, you know, the weekly schedule can be a little difficult on them, but I still think it's fantastic that we're getting an extra tool in the bell, right, to use for them and eventually help them keep delaying and sustaining their quality of life.
Yeah, and I think the mucositis being the side effect, I think we have experience with treating mucositis, you know, being aggressive with like the dexamethasone elixir.
Yes,
so I think since we have that experience, we can counsel the patients better. And hopefully if the quality of life is good and side effect is less, it balances maybe the coming for an IV treatment.
Yeah. Obviously, you know, all of us have the privilege to being able to practice in a setting in which we are focused on one specific tumor type. I will say for our colleagues in the community, you know, when we discuss the details of the trials and we are able to really get into detail, you know, we have that luxury. But I will say, and I want to get your thoughts, what are your advice or what do you see as a, you know, a talking point or a teaching point for this community oncologists that are dealing with these patients? Any, I will say, advice that you want to give them as far as, you know, how to sequence these patients, how to monitor them? I know this is a very broad question, right? Yeah. And I just want to get your feedback and your thoughts on, you know, what kind of advice or how would you, you know, treat these patients with the current landscape, knowing that it's getting so complex. And don't get me wrong, this is a great problem to have. Yeah. We have a great problem in our hands. But any thoughts on that?
Yeah. If someone's making an AI tool, I will invest in that. Where, you know, the landscape is so complex, so we need a manual, right? And sometimes the decisions are so subtle that I will brainstorm with my other breast oncologist colleagues too. And sometimes there is no right option. And it's more of a discussion with the patient and what is right for them, right? The right drug for the right patient. So I really think that it's going to get even more complicated as we have more and more options. And even when we get to that point, giving that patient a single agent AI at that point maybe not be a wrong answer, you know, for the right patient. So I definitely think that we need some sort of an AI tool where we can put all the information. It gives a more reliable option summary, not like, you know, a meticulous jargon. and I will invest in it.
It's about, to me, it's like a clonal evolution, right? Like, so you,
Yes.
ideally you want to prevent the disease to explode, because if the disease explodes and you're going to have 3-4 different sites where the cancer is progressing, then you have potentially 3 or 4 different clones, and then it becomes more challenging to understand which one is driving the disease. So that's why you want to be able to act when you have limited burden of disease and you have a higher likelihood of obtaining a deeper response and keeping the disease stable. And if you have more than one mutation, try to sequence through them. In the past, I will tell you, I don't know if to call it successful, but with a couple of my patients that already had progressed on chemo and they had an ESR1 and I put them on a SERT, and I got some mileage, right?
Yeah.
And I think it has to do with, again, clonal evolution. Maybe the clone that we had selected was already so chemo refractory that end up, being endocrine sensitive again. So we don't know. It's just that we need to make sure that whatever information you gather, just keep it in your back pocket and you may be able to utilize it for later. In terms of toxicity management, I think that it's difficult, but it's important. These medications, I don't conceive them to be as, I'm going to give you a script and I'll see you in 2 months, right? These patients need to have some form of close follow-up, because if you're able to detect the toxicity early when it's low grade, you're going to have a better chance at controlling the toxicity and allowing the patient to stay on treatment for longer, right? Versus if you just prescribe it and the patient doesn't show up for another 2 months, and when that happens, the patient has grade 3 toxicity, chances are you won't be able to control that on time, and then you're going to burn that bridge a little too early, too soon.
And one final point that I would like to make is MRD and ctDNA is coming our way. We cannot have a conversation about oncology in 2026 without having some thoughts on that. So that will be kind of my final question to you.
Yeah.
I'm curious to see how you see this technology evolving in patients that have PIK3CA mutations and patients that don't have PIK3CA mutations. I mean, where do you see a place in this coming forward? Any thoughts?
Yeah, I definitely use it. And I think I don't exclusively make a decision just based off on ctDNA in most cases. Of course, if they have an ESR1 mutation and if they're really symptomatic without bone mets, I may switch them to a SERD with SERENA-6 data. The problem again is Cami is not FDA approved, so it's apples to oranges, switching them to elacestrant or imlunestrant. And I think a lot of people are adopting that, and it's very well adopted in one community, but not in another. It's the opinions are very bifurcated. But I do think I use it more for trending. I use it more for prognostication, more patient discussion. We do need more trials that are more interventional, looking at ctDNA, making a change that leads to longevity. And I think that's where the landscape will 100% change.
Yes.
Yeah, I have a different approach. So I've been using some of the MRD, but to try to de-escalate. Not in ER positive or triple negative, only in my HER2 positive patients, right? We all have patients that achieve these beautiful responses, going to remission on HER2. It's been 2+ years, and then you're second guessing, okay, is the patient cured? Do I need to keep the patient on treatment? So I'm having, of course, an active discussion. I'm doing scans, and if my scans are clean, I'm also doing MRD. And if the MRD is negative, then I'm discussing, okay, well, it looks like maybe we're in a position where we can safely de-escalate and just keep tracking, with Natera or MRD testing every so often. I would say it's very anecdotal. I only have 2 or 3 patients where I've done that, but it has allowed me to kind of reinforce the idea of the escalation of therapy on some of these patients. In ER positive, I think that the approach of proactively doing surveillance for the ESR1 clone would make sense, because you can then be able to limit the explosion of the disease and prevent these polyclonal events, right? Which are the ones that eventually force you to switch to a broader nuclear option, like chemotherapy. So if that eventually is going to allow patients to stay on better tolerated treatments for longer, you would expect that to significantly improve their quality of life, like they show in SERENA-6, and also to potentially translate into survival.
Very nice. Well, I do appreciate your honest thoughts, and I thank you for your time. And it was a pleasure, and it was very much fun to have this discussion with the two of you. So thank you.
Thank you.